Hello, everyone. Welcome to join us at the MIDD Plus 2023 Clinical Track program. My name is Tom Sun, VP of Strategic Consulting Services at Cognigen Division Simulation Plus. It's my pleasure to introduce the next speaker for the poster presentation. It's Dr. Beth Ludwig. She is Associate Vice President, Quantitative Clinical Pharmacology at Simulation Plus. And she will be the presenter for this poster focused on the population PK and ER exposure response analysis for Nivolumab for combination therapy in the oncology indication. So, Beth, welcome, and please start your presentation. Thank you.
Thank you, Tom.
I'm sorry, Beth. My apology. I need to have a housekeeping remark as well. By participating this session with the Q&A and the presentations that you're allowing us to contact you for follow-up questions. The reason is we really take your privacy rights very seriously. Secondly, if you have any questions, please use your Q&A tab on your dashboard to type in any questions for Beth. We will either answer here or the next sessions with all panels together. And if you have any technical questions, please type in the chat function. And so our staff will try to assist. Beth, without further ado, here's your presentation. Thank you very much.
Thank you, Tom. Hello, everyone, and thank you for attending this poster presentation. This poster was originally presented at the ASCPT 2022 annual meeting. So Nivolumab is a programmed DEF1 receptor blocking monoclonal antibody that binds to the PD-1 receptor and blocks its interaction with the ligands PD-L1 and PD-L2 to restore anti-tumor immune response. A critical Nivolumab study, Checkmate 649, is a randomized open-label phase 3 study that demonstrated a favorable benefit-risk profile of Nivo plus chemo over chemo alone in patients with non-HER2 positive, unresectable, advanced or metastatic gastric cancer, gastroesophageal junction cancer, and esophageal adenocarcinoma. And these patients had not received prior systemic therapy. So the pharmacometric analyses that I'll be discussing today supported the benefit-risk characterization of the two Nivo plus chemo regimens. And those two regimens are Nivo 360 Q3 weeks plus Zelox, or Nivo 240 milligrams every 2 weeks plus Folfox. A Nivo population PK model was developed based on a previously developed model using approximately 9,000 serum concentrations from 1,825 subjects who were enrolled in 7 Nivo clinical studies to characterize Nivo PK in these gastric cancer patients and to assess the impact of the baseline covariates on PK parameters. Using empirical Bayes estimates of PK parameters, measures of exposures, for example, CAF, Cmax, and Cmin, following the first dose in its steady state were simulated and summarized. The exposure response analysis included data from 1,581 subjects who had serum concentration data and received either Nivolumab and chemotherapy with Folfox or Zelox or chemo alone. I've listed here the chemotherapy regimens. For Folfox, 3 drugs, and for Zelox, 2. Exposure response relationships for efficacy were characterized by evaluating relationship between Nivo exposure and progression-free survival with CPS and overall survival. CPS is a biomarker that is reported to be associated with the efficacy of anti-PD-L1 therapy. For safety analysis, the first occurrence of grade 2 or higher immune-mediated adverse events were evaluated using a Cox proportional hazard model. For all the ER analysis, significant covariates were assessed based on a 95% confidence interval without adjustment for multiplicity. Both the ER efficacy and safety analysis were performed in 3 steps. first to identify the appropriate exposure matrix, then to select the functional form of the ER relationship, whether it be linear or log linear, and then to assess interaction between nivolumab and chemotherapy. So model comparisons were performed using BIC values. In this slide, we can see a study design schematic, and all subjects were randomized in a 1-to-1 fashion to either of the two nivo plus chemo regimens or to either of the two chemotherapy alone regimens. Subjects entered the trial and then remained in the trial unless there was tumor progression, adverse events, or for a 2-year duration. So the PK model that was developed was a 2-compartment model with time-varying clearance using a sigmoid Emax function. What we're looking at right now is graphical representations of the covariate results of, the covariate effects, either continuous covariates or categorical. So on the left-hand side over here, you can see the effect value with the 95% confidence interval. And down at the bottom, we can see that the covariate effect is expressed as a percent of the reference value. And these two vertical lines at 80 and 120 represent a range, so that if an effect value is shown within that range, it's deemed to be clinically not relevant. So one of the interesting covariate assessments was subject type. And so the first line gastric cancer population was tested against a reference being second line non-small cell lung cancer. And you can see that that was not a significant covariate. In terms of continuous covariates, we can look at the effect of weight on clearance. We can see that from a weight at the median point to the 95th percentile, clearance increased 26%. And for VC, it increased 22%. For baseline albumin, looking at the values between the median and the 5th percentile, there was a 31% increase in clearance. So looking at the summary statistics of exposure for nivolumab 240 versus 360, we can look at the geometric mean values and look at 6 summary measures of exposure related to CAV, Cmax, and Cmin, either at first dose or steady state. As expected, the first dose exposures were higher for all 3 exposure metrics for the Nivo 360 regimen. However, at steady state, we can see C average was pretty similar in both groups as well. Cmin was similar also. And the difference between Cmax when calculated as a percent was much smaller than at the first dose. So here we're looking at the predicted geometric mean 90% prediction interval for nivolumab concentration time profiles for 16 weeks by dosing regimen, where Nivo 240 is the pink with orange and Nivo 360 is the blue with green. What we can see here, excuse me, at the first dose is that the both peak and trough for the 360 regimen is higher than the 240, and we can see that there's really not much overlap in the prediction intervals. We move out to week 12 when both doses are given together according to their dosing intervals. We can see that the trough level is very similar at this point, and there's much more overlap between the 90% prediction intervals. So the results for the population PK include the fact that Nivo PK, including data from first-line gastric cancer patients, was well described by a linear 2-compartment model with time-varying clearance. Nivo PK properties in subjects with first-line gastric cancer treated with Nivo and chemo were similar to those in subjects with second-line non-small cell lung cancer and also second-line or higher gastric cancer treated with Nivo monotherapy. Overall, none of the covariates explored were found to have a clinically meaningful impact on Nivo PK. And as we saw, steady state exposure measures in the first line gastric cancer patients were comparable between the two Nivo dosing regimens. So moving on to covariate effects, moving on to the exposure response analysis for efficacy, where the endpoint was PFS. The base model was included Nivo Cmin1 as the exposure, using a linear function, and there was no interaction between Nivo and chemotherapy. What we're looking at here, again, would be the results for the addition of covariates into the full model. And we can see the hazard ratio and the 95% confidence intervals. For this analysis, the significant covariates, where the confidence interval did not cross 1, are liver mets, performance status, the ratio of LDH to upper limit of normal, baseline albumin, and age. And also we can see here the estimate of exposure for the covariate effect of Nivolumab Cmin1 for both dose regimens are down below the hazard ratio of 1. And we can see that it looks like the results overall are generally similar for both dose regimens. As well, there's a trend towards higher exposure with mathematically lower values of the hazard ratio. However, there is overlap between the 95% confidence intervals for the 5th and 95th percentile values. So for model evaluation, a VPC plot of observed and predicted median with the 90% prediction interval of PFS is shown by treatment. And we can see that there is very good agreement between the observed and the predicted over this time period. And what this means is that the model is adequate. So for the exposure response of OS, the base model was very similar to what we described for PFS, in that the exposure that best predicted OS was Nivo Cmin at the first dose. It was a linear function, and there was no interaction between Nivo and chemo. So again, looking at covariate effects, we can see that the presence of signet ring cell, performance status, ratio of LDH to upper limit of normal, baseline albumin, were all significant. And then again, we can see fairly similar results for the effects of Nivo Cmin1 for both the 360 milligram dose regimen and the 240. So the VPC plot for observed and predicted also looked very good. Again, good concordance between observed versus predictive, indicating that the model was adequate. So the results for ER efficacy for PFS and OS were that Nivo and chemo improved PFS and OS relative to chemo alone within the Nivo exposure range produced by the two dosing regimens. Apparent ER relationships were determined for PFS and OS, but these two apparent relationships are likely steeper than the true ER relationship due to potential confounding effects of PK disease interaction. So for PFS, the risk of disease progression was higher in subjects with younger age, liver mets, ECOG performance status greater than 0, and lower baseline albumin. For OS, the risk of death was higher in subjects with the presence of signet ring cell, ECOG PS greater than 0, higher log ratio baseline LDH to upper limit of normal, lower baseline weight, and lower baseline albumin. Also, OS was longer in the Asia region compared to other regions. So for the safety ER analysis of the occurrence of first occurrence of a grade 2 or higher IMAE, the base model was a little different in that the most predictive exposure that was included is Nivo C average, which takes into account the time course of exposure from day 1 to the time of either an event or sensor. In this case, a log linear function was used, and there was an interaction between nivolumab and chemotherapy. Again, looking at the covariate effects, the one that was significant was the ratio of LDH to upper limit of normal. We can see here for chemotherapy, Zelox had a higher hazard ratio compared to Folox, but was not significant. As we look, as we look down here at our exposures, we can see C average and at both dose regimens was associated with a hazard ratio greater than 1. Again, we see that same pattern where with higher exposures, there's a tendency towards mathematically higher hazard ratios. But in general, it looks like the results are similar between the two dosing regimens. So the VPC plot for the safety analysis, again, showed good concordance between the predicted and the observed data. Again, indicating that this model is adequate. So the results for ER safety show that Nivo plus chemo had a higher risk of grade 2 or higher IMAEs relative to chemo alone within the Nivo exposure range produced by the two dosing regimens. The magnitude of the grade 2 or higher IMAEs risk was similar between the two regimens, but the risk was higher with higher Nivo exposure. And the log ratio of baseline LDH to upper limit of normal was a significant covariate associated with grade 2 or higher IMAEs, and the risk of grade 2 or higher IMAEs was higher with a higher log ratio of baseline LDH to upper limit of normal. So the overall conclusion was that the PK and the ER analyses demonstrated that the two Nivo and chemo regimens have similar Nivo exposure at steady state and improved benefit over chemo alone in 1L gastric cancer subjects, first-line gastric cancer, resulting in similar benefit to risk profiles. And I just wanted to show the full list of authors for this poster, including the team from Bristol Myers Squibb, Haitao Yang, Valerie Poulart, Ling Gao, and from Simulations Plus, Julie Passerell, Heather Barcombe, and David Jaworowitz. Thank you very much.